A very good afternoon to all of you and welcome to this special session on Can we afford to lose gains made in the fight against HIV and TB? Integrated responses are a must to meet the Sustainable Development Goals, or SDGs as they are known as, by 2030. This session is jointly hosted by AIDS Society of India, Citizen News Service, Lilly MDR TB Partnership, Gujarat AIDS Prevention Unit, ISRCDE, ARUNA, and Vote for Health campaign. We heard recently the Minister of Health of South Africa saying, "We will not end AIDS without ending TB." We also know that at the 2015 UN General Assembly, governments had committed to achieve SDGs by 2030. One of which goals is to end AIDS and TB by 2030. If people living with HIV continue to die of TB, we will fail to achieve these goals for which the countries have signed on the dotted line, and also lose gains made in the fight against AIDS and TB both. Saving lives from TB is not just a public health imperative, it is also a social justice imperative, so do we believe. Without any further ado, let us hear brief expert comments from our distinguished panelists before we open up for question and answers. Voices of affected communities are central to improving responses to TB and HIV. We have with us today Nomampondo Barnabas, Civil Society Liaison Officer, International Union Against TB and Lung Disease, the Union. She is globally known for her contribution to TB and HIV and will share her personal experience of both HIV and TB. Over to you, Noma.
Thank you, Shobha, and good afternoon, ladies and gentlemen. Firstly, I would like to respond to the question, can we afford to lose gains made in fight against HIV and TB? And the response is a big no, we can't. And as you've quoted the comments from the minister, one of my experiences is that we tend to really, when we talk about responding or the programs, we look at figures and forget that there's a human behind that figure. That figure is for a person. Before HIV and before TB, there was a person. So as I'm talking about my experience on living with both HIV and TB, since we're talking about integration, because somehow we have the tendency when we develop our policy and programs of working in silos, where we remove and deal with one epidemic at a time. And at the moment, we are seeing the reality of co-infection of TB and HIV. So whatever we programs and activities that we bring on board, we need to integrate. And what also, we as a person living with HIV and who had TB, I think it's high time that, yes, we get people who talk from concern, speaking on our behalf, but I don't speak on behalf of, I speak as one of them, because I live with HIV since 1997, so I think my HIV is now 19 years old. Sooner or later, it's going to grow to become 21 years. And then I had TB, and I was fortunate because I was diagnosed with TB in 2006, shortly after the MDR breakout, and I was here in KZ, and by that time, fortunately for me, it was just an ordinary TB, which was treated within 9 months, and I was fine. And as we're looking at gains, I was nearly, the diagnosis was such a mission because I had a complicated TB to diagnose. I had to undergo culture, which I had to wait for 3 weeks before gene expect. And if I was not in my capacity to push for treatment, maybe by the time the culture results came back positive, they must have missed. I felt that I was going to lose my life because even the CD4 was down to 63. So imagine somebody with a CD4 of 63 and a viral load of 529,000 with TB that is being misdiagnosed. So while waiting for culture, I still feel that I really also could have lost my life. But because I was able to stand up and say, I need treatment, initiate me on TB treatment, and I was initiated. And here I am again, standing and alive today. Thank you.
Thank you, Noma. We have the honor of having with us today the WHO Global TB Program's key person on TB and HIV and co-chair of TB 2016, Dr. Helices Getahun. We will like to compliment him for his leading efforts to bring conferencing on HIV and TB together, apart from his work on strengthening collaborative responses globally. Over to you, Haley.
Thank you very much. So, just to start about TB and HIV, talking in a separate and a different way, and it is clear that we come across long way, particularly in the last decade, and the fact that we are having the TB 2016 as an integral pre-conference part of the AIDS 2016 conference is a clear indication of our journey that we are really documenting progress. And this is also a reflection of what we see in terms of progress in countries and implementing the collaborative TB/HIV activities of WHO that was first coined in 2004, which actually led to averting up to 6 million, nearly 6 million days of people living with HIV. So this is a long way. But however, we are still lagging behind. TB is still the leading killer of people living with HIV. And we haven't yet got all people living with HIV who develop TB every year. We are only getting half of them. We are also not taking care of TB at an earlier stage as we should do. So there are a lot of missed opportunities. So in the era of Sustainable Development Goal, which are, by the way, gives us a very unique opportunity of coming together and working together and looking the person as a person in a holistic manner is inevitable. We have to do it. And for that, programs should consider services and methods and mechanisms that will help them to provide integrated TB and HIV services for people living with HIV and for those people who develop TB. And that is the minimum. According to our WHO guidelines, the minimum expectation from TB and HIV programs is to provide integrated TB and HIV services. And not only providing integrated services, but we have to look also into the broader program efficiency. We have to look where we can garner efficiencies between the TB and HIV programs. We have to find ways to harmonize the way we work, the way we synergize, our efforts, as we have to see the patient in a holistic manner. And the Sustainable Development Goals have a very ambitious targets embedded there, which also includes the ending both the TB and the HIV epidemic and eliminating TB diseases among people with HIV should be the starting point. TB is a curable disease, and it is really unacceptable in 2016 that a person living with HIV is dying of TB. So we had a high-level forum in June in New York, linked to the high-level forum on HIV/AIDS, where we have a ministerial panel, and this message was clearly stipulated in that session, where governments and countries now have to brace up to eliminate TB days among people living with HIV. To do that, we need closer working relationship, we need closer harmonization and synergy, as well as looking for efficiencies. Without that, we cannot say that we are really bracing ourselves for the implementation of Sustainable Development Goals. Thank you.
Thank you, Eli. Science plays a defining role in evidence-based policies, programs, and actions on the ground. Dr. Padampriya Darsini, Senior Scientist, National Institute for Research in Tuberculosis, Indian Council of Medical Research, is here amongst us. Over to you, Padma.
Yeah, I'm on. Thank you, Shobha. So, as a researcher, as a clinical researcher, my opinion for can we afford to lose gains made in fight against HIV TB? Of course, the answer is no. But how else do we sustain the gains that we have made, or how do we increase the gains that we have made? So my opinion would be we would like to see more political commitment from all the countries involved to reach the SDG. So we do agree there has been a decline in TB death in HIV, but it's not what we expect. 36% decline is not a great decline. So we definitely request a bigger political commitment from all the countries, especially the developing countries, towards attaining this goal of reducing the deaths, TB deaths among HIV infected. The other thing I would like to say is the research findings. As a clinical researcher, the research findings that are that come out of any clinical research in any country, it takes pretty long for it to reflect in the program. So if the commitment is also there to bring a faster mechanism to get the research finding for public health, for use for patients, that would be another way we can kind of maintain or even increase the achievements that we have reached to control TB and HIV. And the last thing I would like to say is about this private sectors getting involved to maintain or to help achieve the SDGs. We find there is a definite dislink or definite gap between the government sectors and the private sectors. I think all of us are working towards the same goal, to end TB strategy or to control the TB death or TB mortality and morbidity in HIV patients. So I think there should be more linkage between private sector and the government sectors. I would personally think this could help us maintain the achievements that we have reached in fighting against HIV and TB. Thank you.
Thank you, Padma. Moving to country experiences, let us hear from Dr. Christopher Zishiri, Country Director, Zimbabwe, International Union Against TB and Lung Disease, the Union. The Union has played a key role in developing TB-HIV collaborative activities in high-burden nations. CNS has documented them consistently from countries such as Myanmar, for example. Over to you.
Thank you very much. I've got a short presentation to just share some of our experiences, which I could demonstrate on. So as the presentation is coming, we all know about Zimbabwe. We are just on the northern part of South Africa, and we have managed to go through the whole burden of HIV in Zimbabwe. Now currently our prevalence is about 14%, but still we are a very, very high burden country in terms of TB. Thank you very much. Next slide. So I'll give you practical examples of the work that we are doing in Zimbabwe. We are a very, very high burden country, and our incidence, which is the number of new cases of TB we are seeing per year, is about 278 per 100,000. Our epidemic is really largely driven by HIV, and our co-infection rate is about 68%. Hence, our strategic landscape in terms of intervention is really integration of TB and HIV services. So the integration is basically a one-stop shop. It's almost like a supermarket. And here is just demonstrating the key milestones that we started by pilot, EC funding to TB CAP funding, which is USAID funding, TB Care 1 USAID funding to PEPFAR funding, and a core project which we did in Ontario. Next, please. So the first was a pilot, which was in 2008. We wanted to see the feasibility of decentralization of ART in 3 high burden sites. That is 2 in Harare and 1 in Bulawayo City. Decentralization, we found that we had very, very good results in terms of uptake. We went on to roll out to 23 sites in urban local authorities, which had very, very successful results as well in terms of uptake and nurse-led activity. Next, please. We also had a co-project in one of our cities, which is Mutare, where we were actually looking at the gene expert yield among people living with HIV. This was a very successful project, as I will demonstrate. Next, please. And currently we are replicating all the milestones that we got in Mutare to the whole clinics, to the 23 clinics that we initiated with. So this is just demonstrating that the intervention package, initially site renovations in the integrated care clinics, the 23 primary healthcare clinics, capacity building in terms of healthcare training, and currently we have got 3 centers of excellence. These are for on-site mentorship for all nurses who are actually coming to learn on integrated TB and HIV services. We had at least some renovations that we did for on-site microscopy and specimen transportation system. This is just bringing the laboratory closer to the patient, hence timely access to TB HIV diagnostics, including expert. That's very important. The key milestones that we are seeing there, very, very important. Not sustained increase in TB HIV uptake by integration of services. Uptake actually increased from 74% in October 13 to December 13 to 94%. You can see that green line. It's a really very important milestone that we observed in Zimbabwe in terms of uptake. And the turnaround time in terms of diagnosis, it plummeted from 1 week to about 24 hours on average. Next. Of course, we have got some key challenges. The gene expert is now rolled out in the whole country. That is the expert machine to detect the tuberculosis bacteria and also to determine resistance. We have got more than 100 machines, but is currently under utilization. Treatment outcomes, we are still at 81%. We consider that suboptimal. We want to increase. Prevention, we've got slow uptake of isoniazid as a preventive therapy. This is really compounded by the current discussions between physicians, experts. Some physicians are against the IPT at this stage. So our strategic outlook, we are rolling out the integrated TB HIV care model to optimize gene expert technology towards use as an initial diagnosis, deployment of expert and monitoring to optimize expert use, operations research, that's another very, very important area, and also phase the scale up of IPT for people living with HIV. Thank you.
Thank you, Christopher. Today it is possible to live with HIV normally. Scientific evidence shows benefits of early initiation of ART. It is possible to prevent TB, treat TB and get cured. However, we need to remember that there are other HIV associated and non-HIV associated co-infections and comorbidities people living with HIV may also deal with. Non-communicable diseases or NCDs, for instance, need a lot of attention in context of HIV too. We have with us Amy Israel, Program Director for Lilly's Global Health Programs, who will shed more light on this.
Thank you, Shobha, and thank the organizers for inviting me to the prestigious panel here. The Lilly has 2 flagship partnerships: the Multi-Drug Resistant Tuberculosis Partnership, focusing on China, India, Russia, South Africa, and the Lilly Non-Communicable Diseases Partnership, focusing on Brazil, Mexico, India, and South Africa. Now, we're trying to improve treatment outcomes closer to the primary care or community care level under an operational framework we call Research, Report, Advocate. So every model that we support has research generated from it. We report out on the data and advocate for the scale up of the pieces that work to government or other donors. Yet, everyone here has had this common theme of person-centered care. What does person-centered care really mean, and how can we have integrated services when many governments don't have as strong of an NCD space structures like they have in HIV or TB? How can we do that kind of integration? So we're testing a few different models in settings like South Africa, where there's such a high burden, quadruple burden, if you will, of TB as the leading cause of death, HIV with such a heavy burden here, diabetes and hypertension. What does that mean, though, in practicality? Someone is going to their clinic to get their ARTs, or maybe a drop-off point, which is great because it's at community level. The TB center for their TB treatment. Then they have to go to a different clinic for their insulin if they're on insulin, or their orals. How many clinics do you want to go to as a person? You want to go to one. So we're really trying to develop that model that can really be that person-centered care for that integration. And Haley mentioned efficiencies in reference to TB and HIV, and we're really trying to find those efficiencies in diabetes and TB and HIV as well. Now, on our side, we haven't worked as much in HIV, and we are committing to have that in high-burden countries as an integrated component, so that we're not part of the problem, but the solution of integration. And we heard about linkage in public and private sectors as well. In India, we're doing a lot of work in the private sector, knowing that people in India are going to the private sector regardless of the economic status as their first point of care. So you're going to go to your pharmacy shop or your local chemist for care first. And so we're doing a lot of support on TB as well as on diabetes for those pharmacists to engage in that integrated care. And admittedly, we could do more. We're trying also with some hospitals, some private hospitals, and have seen treatment adherence rates increase to 95% for TB due to a mobile health opportunity as well as a virtual counselor. So there are some chances, but we've got to work together in finding those solutions. Lastly, I'll just say as a plug, we've got a session on integrated care on Tuesday morning at 7 a.m. in session room 6, and we promise to feed you. Given that it's early, you'll get breakfast if you come. Where we'll have 2 people affected by multiple diseases speaking their stories from South Africa, as well as panelists from the Executive Secretary of Stop TB, the Global Fund, implementers, and frontline health workers. So we hope you can make it.
Thank you, Amy. And now we open the floor for the question and answer session. Please be welcome to ask the questions. Yes, please. I think there's a mic there.
Yes, whichever way. Thank you. Hi, my name is Anna Miti. I'm with the Zimbabwe Broadcasting Corporation in Zimbabwe. My question is directed to the WHO. One of the issues that we've been having with TB has been, just like with HIV, is the number of people who are living with HIV but don't know that they are living with HIV. The issues of, cases that have not been diagnosed because somebody doesn't even know that they have this disease. How are you working, as the WHO to further with the gains that have already been made in TB, by getting treatment to such people and getting those people to know that they have TB?
Thank you for that question. And it's true that we are not actually getting a third of the TB cases that we believe or we estimate are out in the community. And if you compare and contrast with people living with HIV, that figure could be even worse when you are considering people living with HIV, because we are only finding 50% of them. So that means there is really a big issue in getting those unidentified or those people whom they don't feel sick into the health facilities and the healthcare system. And for this there are several mechanisms, and one and the most important thing is really to promote integrated community-based activities. And when I say integrated community-based activities, is basically to look for all diseases as much as the epidemiology and the local context of that area permits. For example, in the context of HIV and TB, if you are going into a household and if you are looking for an HIV person, or if you are really looking or advising or monitoring treatment for a TB patient, not asking about HIV and or vice versa is not acceptable, and it should be. It shouldn't be a standard of care. So number one, we have to raise that awareness of the community health workers or the community members, and including the whole system of health workers, to be always suspicious when they are treating one either HIV or TB, and then they will think of the other disease. And in addition to that, and it's clear even for HIV, people estimated to live with HIV. We are not yet there. We are not finding those people, and yet we have a very rapid and simple blood test. When you compare that to TB, it's not comparable. In TB, diagnosis can only be done in a health facility, in a laboratory, which is totally different from HIV. So really having scaled up the HIV testing in the context of 90-90-90 would actually also help to address the problem linked with HIV-associated TB. So we strongly believe and support the 90-90 UN's fast-track targets would really help us to also raise this 50% undetected HIV-associated TB in the community.
Thank you.
Thank you. My name is Lungile from Slovene News. My question is mainly directed to the lady from Lilly. It's in connection with the diabetic children, especially because I've had cases whereby the children, they have to take their GM machines to school. And how safe is it? Because you find that some kids might play with the machine, especially the pen that they use to prickle their fingers, and then maybe you find that whatever child that is playing with that pen is diabetic, and then is HIV positive, and the diabetic child use the pen and end up being infected. Is there any way that is being looked at to find another way of crinkling the finger when you are checking the diabetes instead of using the pen? Because I've spoken to some, because I have a diabetic child also, so we normally have these meetings as parents with diabetic children, and this issue has been raised because some parents end up being scared of sending their children with the machine so that they can do their checkups while at school because of this issue, because they find that some children end up playing with the machine at school.
I think you raise a good question that has not one good answer. First of all, I'm not a clinician, and I'm not someone that knows how to use devices or recommend how to use devices in a safe way. But I do know that many schools have policies on how to use, where to use the devices for safe use. I can tell you from a personal experience that I used to use a device that had a needle growing up, and the school made me keep it in the in the office. So there's ways that can be safe. but also, there's in talking to schools. Now we're doing a program with children with type 1 diabetes in Brazil, where we have educational material for the children on how to take care of themselves as well as for the parents, how they can help take care of their kids better, and it's using online as well as interactive materials. We're seeing good results with that. Part of that is how to use the products that you have. So education is crucial, both for the people affected by the disease, their family, as well as the community around them. And I think it starts with one person in a community like a school. Then there's an opportunity to help educate on the right use and the effects of the testing or the diabetes on the community there.
My name is Mira Nsingo. I'm a journalist from Zimbabwe, Harare. I'm directing my question to WHO and the union. How are you working with how to reach communities, suppose especially religious sectors, because we have realized we have some people who don't even access medical care at all. I'm sure there could be really a lot of missed cases of TB. Then the reality is, I think with developing countries, we are heavily dependent on donor funding. And in the face of changing political dynamics, how at least are you trying to engage those countries so that at least they try to fund their own programs, especially TB and HIV? Thank you.
Thank you very much. I will talk about the second question, and my colleague here will talk about the engagement of the religious sector. I'll give again a practical example, like in Zimbabwe. Yes, I know we are mostly donor funded in our tuberculosis control program, particularly from Global Fund and also from USAID through Challenge TB. However, what we have embarked as one of the objectives under Challenge TB, which is USAID funding, is to garner for political support in terms of increasing the fiscus generally for the Ministry of Health, and also for the TB budget within the ministries. We know our governments, we are a resource poor setting, but however in Zimbabwe we have already started engaging parliamentarians. We have got a parliamentary caucus on health, which is also responding to the Barcelona Declaration, which was at the Union Conference in Barcelona, that is 2014. We have got the highest number of parliamentarians who have signed to the declaration, and we have got a health select committee which is very active, working with the National Tuberculosis Control Program in the country, and very, very supportive to the TB control program. So we have actually harnessed our politicians to support TB. Zimbabwe has always been known to be in the forefront in terms of HIV and the National AIDS Council, and the contribution of every civil servant to that fund, which is now funding medicines, which is now funding the program in terms of HIV. And we are saying as TB, the same can also be done, and we are actually in a very positive pathway to ensure government fiscus and government political support to TB tuberculosis control.
Okay, just to add on the issue of reaching out to those hard to reach. My role within the union, I'm staff member for the union as civil society liaison officer to mobilize and coordinate civil society activities that are related to the union. So far, amongst those, we have a project that we have started as far back as last year from Cape Town of working with religious leaders. We had a pastor who was part of the panel of the plenary who spoke strongly about the importance of engaging faith-based leaders. That led to a summit that we had on Friday, this Friday before we came here, with different faith-based leaders, interfaith, if I can put it that way, specifically from KZ. And at the moment, it's a pilot project. We hope that, because most of the time people would really listen to their pastors. And this morning, we were part of the launch of the TB caucus, which was the next street from here, which was presented by our National Minister of Health as part of Stop TB Partnership. So we are working closely with faith-based leaders.
Hi, I'm Tina from Deccan Chronicle and Asian Age Newspaper India. Since both of you have worked in India, I just want to ask you one thing. We made huge gains in bringing down AIDS and HIV prevalence. And then suddenly, we felt maybe self-satisfied and we felt contented. And, the amount of the success or the rate that you see now is nowhere now. We are just, either we have got complacent or whatever has happened with the government or whatever. I think you know better. So what exactly do you think? Is it a time to be there and just get self-satisfied and not do anything? Or what do you expect from Indian government, or what do you think about the progress that we have achieved so far?
No, we're not satisfied with the progress that we have made so far. So we still have a long way to go. And though there is a slight lull, I don't say we have gone back or we have become silent or we have become complacent. Maybe the memento which was there initially has kind of slowed down, that we've reached the plateau. But it can always, we can again go back to the thing which we started. I would think we would need a little more of, the main problem there is funding. So, so all the research fundings have been cut down by 50%, NACO funding has been cut down, ICMR funding has come down. So there is across the board there is cut down in the funding from NACO, Central TB Division, as well as ICMR. So I think if we can vouch back or we can get back the political commitment and the funding to the level that was there initially when we started. This year the funding for NACP4 has increased. Yeah, it's gone up from what it was last year, but still it has not reached where it has to be. So if we can bring more private sector involvement, funding from the pharma companies, funding from India, Bill Gates, so more political commitment and funding will take us back to where we were, where we are supposed to be. So maybe media should help us, get back the funding that was originally earmarked for NACP, for CTD, as well as for RNTCP, for NACP, and for Indian Council of Medical Research.
I think the focus also got shifted because the numbers had already gone down and the government.
Can you use the microphone?
Do you think that maybe because the government thought that the numbers have already gone so down, so their focus shifted?
The numbers of HIV have gone down?
Yeah.
Okay, but then second line and third line have gone up. The failures have gone up, resistance has gone up. The NACP4 has got the money, but it's not, the money promised to say RNTCP has gone down, but we have also got newer drugs now. We've got more resistance, XDR and MDR increasing in numbers. So the focus should be, I think the focus should be more on getting drugs, easy access to drugs, easy access to investigations. The government is doing, I'm not saying that it's not doing, but we've also got now 300 expert machines placed in all the different places. They're doing, but the commitment should be a little more and funding should also increase to all levels, not only to the government sector, also to the private sectors. Getting involvement of all the private hospitals and the management. For example, if you have new drug bedaquiline is currently accessible only through program. The new drug for XDR, drug-resistant TB. So I personally think commitment and funding are the two things which we need more in the country to get back to the memento which we originally had.
But actually also, I think they've been able to put just 3 patients as of now, just 3 of them.
24 of them.
24, now?
It's increasing. I mean, it's increasing in all sites, but it was a little late by the time bedaquiline could be rolled out in the country, but it's increasing and we'll reach there. There are so many hurdles before we could put somebody on bedaquiline, all the basic requirements, basic investigations. Yeah, probably in another 6 months we'll have more number of patients started on the new drug.
Hello, my name is Rita. I'm a journalist from Indonesia. It's far away from here. I would like to ask Amy and also Dr. Harris from WHO. Indonesia has 60 million people with diabetes, and many of them do not know that they have TB. Also, Indonesia has a large population with HIV, people living with HIV, but many of them belong to key population which do not have access to treatment, to testing. So what do you think our government should do? Because we don't have enough infrastructures to reach out to diabetes patients and also people living with HIV/AIDS. So I want your suggestion. Thank you.
So on the TB diabetes angle, you know, there's the international recommendation for bidirectional screening for people who have TB to be screened for diabetes and vice versa. What we're seeing both in the evidence and anecdotally is that it's working stronger on the TB side. Why? Because the vertical program has had larger funding, there's more focus, etc. Now, what can you do in a country where the diabetes side of the NCD side might not be as strong is really working with local government, provincial or state government, and then as well as national government for implementing that policy on the diabetes side. It's a very quick questionnaire for people who have diabetes to screen for symptoms. It's a very quick assessment on the other side as well. But as it needs to be a priority for the government as well as the clinics. Where we are seeing success is where the government, like the municipal level government, has taken it on board. They've put it in their treatment cards, in their registries, and it's a reminder to do that screening. And then the next challenge is that linkage to care once someone is found out, since they're often at two separate places, but that's a whole nother story. Right.
Yeah, so I think the other thing should be the role of civil society in such situations, really to reinforce that these are of public health importance, the interaction between TB and diabetes and TB and HIV, and really ensure governments took the responsibility seriously, and really ensuring that the interventions and the adoption of internationally recommended policies are integrated or into national policies, as well as national plans, investment plans will be extremely important. And in terms of addressing TB and diabetes, WHO has actually a framework that clearly recommend what needs to be done by national programs, both the TB as well as those programs who are taking care of non-communicable diseases. And this framework is actually based on the experience of the TB/HIV collaborative activities, which requires collaboration between the two programs. So ensuring that framework is also implemented, adopted first and then implemented will be extremely useful.
Okay, I've asked this question before in other press conferences, but I still want to know about the research and development in terms of pediatric TB. We know that it's harder to diagnose TB in children, and also the issues of treatment, where they are still getting adult formulations and trying to get them in children's sizes. Are we likely to see any research around pediatric TB along those lines?
the challenge of pediatric TB of diagnosis is, of course, universal, but it's also related to the overall diagnosis of TB. Of course, children, they couldn't produce a sputum, and the sputum is still, the main specimen that we have to use for diagnosis. But whatever tool we will develop, the ultimate solution will be really to have a rapid point of care test or saliva test or urine test that could really help us to identify the disease regardless of age. And that's part of the the overall challenge we have, and that's why the end TB strategy, the WHO end TB strategy, which is now embraced within the Sustainable Development Goals, actually